Dear students, Assalamu alaikum. In this lecture, we will continue with the discussion on chronic kidney disease. Injury to the renal interstitium is the third major cause of chronic kidney disease after the first two causes, which are injury to the vasculature and injury to the glomeruli. Now remember, primary or secondary disease of the renal interstitium is known as interstitial nephritis. In general, this condition, injury to the renal interstitium, can result from vascular, glomerular, or tubular damage that destroys individual nephrons. However, this can also result from a primary damage to the renal interstitium by poisons, drugs, and bacterial infections. Renal interstitial injury caused by bacterial infection is called pyelonephritis. Pyelonephritis. The infection results mostly from an organism called Escherichia coli that originates from fecal contamination of the urinary tract. With long-standing pyelonephritis, in addition to damage to the renal medullary interstitium, there is also progressive damage of renal tubules, glomeruli, and other structures of kidney. Nephrotic syndrome. Nephrotic syndrome is characterized by loss of large quantities of plasma proteins into the urine. The cause is increased permeability of the glomerular membrane. Therefore, any disease that increases the permeability of this membrane, glomerular membrane, can cause the nephrotic syndrome. Now let's study some of the diseases increasing permeability of the glomerular membrane. And the number one disease is chronic glomerular nephritis. This affects primarily the glomeruli and often causes greatly increased permeability of the glomerular membrane. Number two is amyloidosis, which is a systemic disease, can be localized also, which results from deposition of an abnormal proteinoid substance in the basement membranes of the glomeruli. Number three is the minimal change nephropathy, which is associated with loss of the negative charges that are normally present in the glomerular capillary basement membrane, and this loss of negative charges cause increased permeability of the glomerular membrane. Nephron function in chronic kidney disease. Now, there are two aspects of nephron function in chronic kidney disease. One is the loss of functional nephrons, which requires surviving nephrons to excrete more water and solutes. Secondly, is the inability of the kidney to concentrate or dilute the urine, called isostenuria. Effects of renal failure. The effects of chronic kidney disease on the body fluids depends on number one, water and food intake by the person, and secondly, the degree of impairment of renal function. Important effects include number one, generalized edema resulting from water and salt retention, acidosis, azotemia, which is the term used to denote high concentration of the non-protein nitrogens like urea, creatinine, and uric acid, resulting from failure of the body to excrete the metabolic end products of proteins. In addition, high concentrations of other substances like phenols, sulfates, phosphates, potassium, and guanidine bases. Now, this total condition, edema, acidosis, azotemia, is called uremia because of the high concentration of urea in body fluids. Assuming that a person with complete renal failure continues to ingest the same amounts of water and food, the concentrations of different substances in the extracellular fluid will be as shown in this figure. Other effects of renal failure may include anemia, which is caused by the decreased erythropoietin secretion by the decreased renal tissue. Other is the osteomalacia, caused by decreased production of active vitamin D and phosphate retention by the kidneys. Now let's study some of the aspects of hypertension and kidney disease. As we studied earlier, hypertension can cause injury to the glomeruli and blood vessels of kidneys. On the other hand, abnormalities of kidney function can also cause hypertension. Therefore, the relation between hypertension and kidney disease can sometimes start a vicious cycle. Hypertension can result either due to renal lesions reducing the ability of kidneys to excrete sodium and water, or hypertension can result because of patchy renal damage and increased renal secretion of renal. Let's first study the renal lesions reducing ability of kidneys to excrete sodium and water. The first of such lesions is the increased renal vascular resistance, which reduces renal blood flow and the glomerular filtration rate. And the example is the hypertension caused by renal artery stenosis. Number 2, decreased glomerular capillary filtration coefficient, which reduces the glomerular filtration rate. And this is seen in chronic glomerular nephritis. Number 3, excessive tubular sodium reabsorption. An example is hypertension caused by excessive aldosterone secretion. Patchy renal damage is the second major cause of hypertension. Now, what happens is that if one part of the kidney is ischemic and the remainder is not ischemic, the ischemic renal tissue secretes large quantities of renin, which act on the which leads to the increased formation of angiotensin II, which act on the non-ischemic part, and that can cause hypertension eventually. Now, patchy renal damage can occur due to renal artery constriction or arteriosclerosis of the renal blood vessels. Now move on to specific tubular disorders. From our previous knowledge, we know that many mechanisms are responsible for transporting different substances across the tubular epithelial cell membrane. In addition to many hereditary causes, damage to tubular epithelial cell membrane by toxins or ischemia can also cause specific tubular disorders. Let's first study renal glycosuria. In this condition, the blood glucose concentration may be normal. However, the renal transport mechanism for tubular reabsorption of glucose is greatly limited or maybe absent. Therefore, despite a normal blood glucose level, large amounts of glucose pass into the urine each day. So, as diabetes mellitus is also associated with presence of glucose in the urine, renal glycosuria must be ruled out while investigating a patient with increased glucose in the urine. Amino aciduria is failure of the kidneys to reabsorb amino acids. Amino aciduria may be generalized amino aciduria, which results from deficient reabsorption of all amino acids. But more frequently, defects of specific carrier systems result in deficiencies of single amino acids, like essential cystinuria, in which large amounts of cysteine fail to be reabsorbed and it crystallizes in the urine to form renal stones. Another example is simple glycinuria, in which glycine fails to be reabsorbed. Renal hypophosphatemia. In renal hypophosphatemia, the renal tubules fail to reabsorb large quantities of phosphate ions when the phosphate concentration of the body fluids falls very low. There are no serious immediate abnormalities because the phosphate concentration of the extracellular fluid can vary widely. But over a longer period of time, a low phosphate level causes diminished calcification of the bones, causing the person to develop rickets. So here keep in mind that this type of rickets is refractory to vitamin D therapy, because this is not because of vitamin D deficiency. In contrast to the rapid response of the usual type of rickets to vitamin D. Another tubular disorder is the renal tubular acidosis. In renal tubular acidosis, the renal tubules are unable to secrete adequate amounts of hydrogen ions. As a result, large amounts of sodium bicarbonate are continually lost in the urine. Now, this causes a continued state of metabolic acidosis. The causes of renal tubular acidosis include hereditary disorders and widespread injury to the renal tubules. Next, we study an interesting tubular disorder called Fanconi's syndrome. Fanconi's syndrome is associated with increased urinary excretion of all amino acids, glucose and phosphate. In severe cases, other manifestations are also observed, like failure to reabsorb sodium bicarbonate, increased excretion of potassium, and nephrogenic diabetes insipidus. The causes of Fanconi's syndrome include hereditary defects in cell transport mechanisms, toxins or drugs, and ischemic injury to renal tubular cells. Barter's syndrome. Barter's syndrome results in increased excretion of water, sodium, chloride, potassium, and calcium by the kidneys. The salt and water loss leads to mild volume depletion, resulting in activation of the renal angiotensin aldosterone system. So there is stimulation of potassium and hydrogen secretion in the collecting tubules because of the action of aldosterone, leading to hypokalemia and metabolic acidosis. The causes of Barter's syndrome include: number one, impaired function of sodium potassium 2 chloride co-transporter. Number two, defects in potassium channels in the luminal membrane. And number three, defects in chloride channels in the basolateral membrane of the thick ascending loop of Henle. I stop here to end today's lecture. We will continue with the study of the some of other tubular disorders in the next lecture.